Okay, let's unpack this. Have you ever looked at your dog or cat and noticed they seem a little off?
Uh-huh.
Maybe they're drinking from the toilet bowl more often, or they seem weaker than usual, or maybe, a young animal just isn't growing like they should.
Right.
Sometimes those seemingly simple things aren't just a bug passing through. They can be a signal of something surprisingly complex happening behind the scenes, particularly with their kidneys.
Absolutely.
Mm.
And it's often happening in a very specific part of the kidney. We usually think of kidneys as just filters, right? Getting rid of waste.
Yeah, the basics.
But they're also incredibly sophisticated chemists. They play a critical role in balancing the body's acids and bases.
Hmm.
And when that delicate fine-tuning system in the kidney's tubules goes awry, you land on a condition called renal tubular acidosis, or RTA.
And that's exactly what we're diving deep into today. We've taken the source material you've shared, essentially a detailed guide to RTA in dogs and cats. And our mission is to pull out the absolute most important insights. Think of this as, well, your shortcut to understanding this nuanced condition. What it actually is, the different ways it shows up, how vets pinpoint the diagnosis, and what can be done to help.
And the key takeaway right at the start is that RTA isn't usually a problem with the kidney's main filter. That part, the glomerulus, it might be working just fine, filtering blood at a near normal rate.
Okay.
The issue in RTA is in the miles and miles of tiny tubes, the tubules that come after the filter. This is where the kidney decides what to reabsorb back into the body and what to leave in the urine.
Uh-huh.
In RTA, these tubes fail at their job of handling acid or base, leading to an acidic state in the body, even though, like I said, the initial filtering might be okay.
So it's a very specific plumbing problem, not necessarily a clogged filter. Let's get right to the definition from the material. What exactly is renal tubular acidosis?
Well, put simply, RTA is a group of disorders where the kidney tubules fail in one of two main ways. Either they can't get rid of enough hydrogen ions, which are, the acid parts, or they can't reabsorb enough bicarbonate, which is the body's main buffer against acid. The outcome of either defect is a specific type of body acidity called a normal anion gap metabolic acidosis.
Okay, that phrase, normal anion gap metabolic acidosis, sounds pretty technical. What's the one thing someone listening should really grasp about that?
It's a crucial clue for diagnosis. Acidosis just means the body's pH is too low, it's too acidic. Metabolic means it's not caused by breathing problems.
Okay.
The normal anion gap part is where the nugget is. It tells vets why the body is acidic. Unlike other conditions like, say, severe kidney failure or diabetic emergencies, where toxins build up and create an increased anion gap, in RTA, you're losing buffer, the bicarbonate, or failing to excrete acid without that major toxin buildup. So the calculated anion gap stays within the normal range.
So a normal anion gap doesn't mean everything is normal. It's a specific pattern in the blood chemistry that points away from some other causes of acidosis.
Exactly. It helps narrow it down.
And this tubular problem, why does it matter so much in dogs and cats? I mean, what are the real-world consequences?
Oh, it matters immensely. The sources highlight that chronic acidosis, even if it seems mild on paper, isn't just a number. Over time, it causes real damage.
Like what?
We're talking muscle weakness, poor growth, especially in young animals. It can mess with bone health, the material notes, a risk for bone issues, although maybe we don't see it as dramatically clinically in pets yet, as in some other species. And importantly, it predisposes to calcium deposits in the kidney tissue itself. That's called nephrocalcinosis. And also calcium-based urinary stones, urolithiasis.
Wow, so just being a bit too acidic systemically can weaken bones and actually cause kidney stones. That's a really powerful downstream effect.
It is, and it's often challenging to spot early because those initial signs, weakness, maybe drinking a bit more, they're so vague,
Yeah, it could be anything.
It takes specific lab work to connect the dots.
But here's where it gets really interesting, pulling from the sources. RTA is often treatable.
That's a key point of hope, definitely. While the underlying cause might not always be curable, you can often manage the acidosis itself and fix the electrolyte imbalances.
And that helps how?
Well, this can dramatically improve how the animal feels day to day and prevent those really serious long-term complications we just mentioned, like the stones, the kidney deposits.
And sometimes finding RTA helps you find a bigger problem lurking underneath, right?
Exactly. Sometimes the RTA itself is a red flag. It can be a symptom of something else going on entirely, like certain toxins, autoimmune diseases, or specific inherited conditions. So diagnosing the RTA is sometimes the crucial first step to uncovering and treating a primary disease you might have otherwise missed.
Okay, let's quickly revisit the kidney's basic acid-based jobs, just to set the stage for the different RTA types. What are the main things the tubules are supposed to be doing here, according to the sources?
Right. So the sources remind us the kidneys have two main goals for acid base. First, reclaiming bicarbonate from the fluid filtered out of the blood. Think of bicarbonate as your body's emergency buffer supply.
Okay, grab that buffer back.
Yeah, grab it back. Most of this reabsorption happens early on in the proximal tubule. Second, actually getting rid of excess acid, those hydrogen ions.
Right.
And the main way they do this is by generating and excreting ammonium NH4+, which effectively carries acid out in the urine. These processes are just crucial for keeping the body's pH stable.
Got it. Reabsorb buffer, bicarbonate, excrete acid, mainly via ammonium. And you mentioned potassium is tied into this somehow.
Yes, potassium balance and acid-base balance are very tightly linked in the kidneys. Problems with acid excretion or bicarbonate reabsorption can directly impact how potassium is handled, particularly in the later parts of the tubules, the distal parts.
Hmm?
There's also a hormone called aldosterone that plays a key role in that distal balancing act for both potassium and acid.
Okay, so the kidney's tubular plumbing handles bicarbonate and acid, is linked to potassium, aldosterone's involved, and RTA is a failure in that system, leading to that specific normal anion gap metabolic acidosis.
You got it.
Now, let's unpack the specific ways this plumbing can break. The sources break RTA down into types based on where the problem is. We're focusing on type I, type 2, and type 4.
Those are the main classifications discussed in the material, yes.
Start us off with type I, the distal RTA. Where's the defect in this one?
Okay, type I. The problem here is in the distal part of the tubule, further down the line, specifically in the cells of the collecting duct.
And their job is?
Their main job is to pump hydrogen ions, the acid, into the urine to make it acidic. In type I RTA, they just can't do this effectively. They struggle to create that necessary steep acid gradient between the blood and the urine.
So what happens as a result? What are the key consequences of that specific pumping failure?
Okay, here's a really crucial diagnostic nugget from the sources. Even though the body is acidic, the kidney can't make the urine appropriately acidic. The urine pH remains inappropriately alkaline. The sources give specific values to watch for, typically above 5.5 to 6.0 in dogs, and maybe a bit higher, above 6.0 to 6.5 in cats. If you see systemic acidosis and alkaline urine, type I is really high on your list.
That inappropriately alkaline urine is a major clue then. What else goes wrong in type I?
Well, because the kidney can't pump out positive hydrogen ions effectively, it tries to compensate electrically by pumping out other positive ions, specifically potassium.
Oh, okay.
So type I RTA is often associated with hypokalemia or low potassium in the blood. It's trying to balance the charge by ditching potassium instead of acid.
And linking back to the consequences we discussed earlier, those calcium issues, does that fit in here?
Right, spot on. The chronic acidosis itself tends to pull calcium out of bone. Combine that with the alkaline urine, which makes calcium and phosphate less soluble, meaning they precipitate out easier. And you have a perfect storm for calcium deposits in the kidney tissue itself, that's the nephrocalcinosis, and an increased risk of calcium phosphate urinary stones.
Okay, so type I, a distal pump failure for acid, leads to inappropriately alkaline urine, often low potassium, and those calcium stone and deposit risks. What does that actually look like in a pet, clinically?
You'd likely see signs of the chronic acidosis and the low potassium. So general weakness, maybe poor appetite, increased drinking, and urination PUPD.
Usual suspects.
Kind of, yeah. If the potassium gets really low, you might see more severe muscle weakness, sometimes that classic neck drooping, the ventriflexion, especially in cats. And of course, if stones have formed, you might see signs related to that, like straining to urinate or blood in the urine.
What can cause this type I defect? Is it something they're born with?
The sources say it can be primary, meaning inherited, though that seems less common. They mention it specifically in miniature schnauzers and basenjas,
Okay.
but more often it's secondary to other conditions. Chronic high calcium levels, hypercalcemia, that's a big one, as high calcium can directly impair how that distal tubule works. Also, autoimmune diseases, certain drugs like amphotericin B and antifungal, and even severe long-standing kidney inflammation or obstruction can trigger it secondarily.
Got it. Okay, let's move to type 2, the proximal RTA. Where's the issue in this type? proximal means earlier, right?
Exactly. This problem is in the proximal tubule, the very first segment right after the main filter. This is where the kidney is supposed to reclaim the vast majority, like 80–90% of the bicarbonate filtered from the blood.
And in type 2?
In type 2, the proximal tubule is leaky, essentially. It fails to reabsorb bicarbonate properly. It's just wasting it.
So they're just losing their main buffer out the grain from the get-go. What happens then? Does the bicarbonate level just plummet?
Basically, yes. The primary consequence is bicarbonate wasting. The kidney just keeps losing bicarbonate until the level in the blood gets quite low. So low, in fact, that the distal tubules, which are usually working fine in type 2, can actually handle the small amount of bicarbonate that finally reaches them way down the line.
Okay, so the body ends up with very low bicarbonate in the blood. What does that do to the urine pH? This seemed a bit counterintuitive in the material.
It is. It's a bit tricky. Unlike type I, in the sort of steady state for a type 2 RTA animal, meaning their blood bicarbonate is already chronically low, their urine can actually be appropriately acidic, often below 5.5.
Really? Why?
Because the distal tubule is working okay, and by the time the fluid gets there, there's so little bicarbonate left that the distal tubule can successfully acidify it.
Right.
The key is, though, if you were to give them bicarbonate, like as a treatment,
Uh-huh.
the proximal tubule still leaks it out, and the distal tubule gets overwhelmed by the sudden flood of bicarbonate, so the urine pH will then swing and become alkaline. That response to a bicarbonate challenge is kind of the diagnostic trick, although it's not a test vets commonly do in practice because it can be complex.
Fascinating. So acidic urine doesn't rule out type 2. How about potassium in type 2? Still low like type 1.
Also often associated with hypokalemia, yes, low potassium.
Why is that?
Because the proximal tubule isn't reabsorbing bicarbonate and sodium as well as it should, more of both get delivered downstream to the distal tubule. This increased delivery of sodium and bicarbonate basically encourages the distal tubule to secrete more potassium to try and reabsorb the sodium, leading to potassium loss and low levels in the blood.
Okay, makes sense. And type 2 has a really strong connection to something called Fanconi syndrome.
Crucially, yes, proximal RTA is very often part of a larger, more generalized problem called Fanconi syndrome.
And what is Fanconi?
In Fanconi, the proximal tubule is essentially broken in multiple ways, not just bicarbonate handling. It also fails to reabsorb other things. It absolutely should keep things like glucose, amino acids, phosphate.
Oh,
And the key here is that these things show up in the urine even though their levels in the blood are completely normal.
so if you see glucose in the urine, but a blood glucose test is normal,
Yeah.
that's a huge red flag for Fanconi, and likely type 2 RTA is part of that.
Exactly. Glucosuria glucose in the urine with normal blood glucose is a classic sign of Fanconi syndrome, along with losing amino acids and phosphate in the urine too. That pattern just screams proximal tubule problem.
So the clinical picture for type 2 sounds like acidosis signs, hypokalemia signs, and those telltale Fanconi signs like the weird glucosuria, maybe protein in the urine, amino acids, phosphate loss, and potentially poor growth because they're losing nutrients.
That sums it up well.
What are the causes here, similar to type 1?
Like type I, it can be primary and inherited. Inherited Fanconi syndrome, which includes proximal RTA, is probably best known in Basenji's.
Right.
But the sources mention it's also seen in other breeds like Norwegian Elkhounds, Labradors, and Border Terriers. But secondary or acquired Fanconi syndrome is probably more common overall.
Acquired from what?
This can be caused by certain toxins, like specific antibiotics, aminoglycosides, such as gentamicin are mentioned, heavy metals like lead, even outdated tetracycline antibiotics, believe it or not, certain chemotherapy drugs like cisplatin. Other potential causes listed include issues with calcium regulation, amyloidosis deposit in the kidneys, certain infections like leptospirosis, or even severe long-standing low potassium itself can damage the proximal tubule. Oh, and multiple myeloma, a type of cancer, is also listed as a potential trigger.
Quite a diverse list of things that can damage that proximal tubule. Okay, now on to type 4, the hyperkalemic RTA. The name gives it away. This one is defined by high potassium, which is different from the first two.
Yes, the hyperkalemia, the high potassium, is a defining characteristic. The problem here, according to the sources, is usually related to aldosterone.
The hormone we mentioned earlier.
Exactly. Aldosterone is the hormone that tells the distal tubule to hold onto sodium and water, and importantly, to pump out potassium and hydrogen ions. In type 4, either the body isn't making enough aldosterone, or the kidney tubules aren't responding to it properly. There's a communication breakdown.
So if the tubules aren't getting that aldosterone signal, or can't hear it, They can't get rid of acid or potassium effectively.
Precisely. The consequences are twofold. Hyperkalemia, because potassium isn't being secreted effectively, and impaired acid excretion, because that hydrogen pump in the distal tubule isn't getting the proper stimulation from aldosterone.
Okay.
The sources also point out something interesting. The high potassium level itself can actually make it harder for the kidney to produce ammonium, which, remember, is the main way to get rid of large amounts of acid. So it's kind of a double whammy against acid excretion.
Right. So what does that do to the urine pH in type C? Is it alkaline like type I?
No, this is another key point of differentiation. Unlike type I, the urine pH in type IV is typically appropriately acidic, usually below 5.5, even though the body is acidotic,
Quite acidic.
because the kidney can still create an acidic gradient. The pump mechanism itself isn't broken in the same way as type I. The problem is its overall capacity to get rid of enough acid and potassium because that crucial aldosterone-driven pathway is impaired. It can make the urine acidic, just not get rid of enough total acid.
Okay, so type 4 looks like an aldosterone issue, leads to high potassium, impaired overall acid excretion, but the urine itself can still be acidic. What does this look like clinically in a pet?
You'll often see signs related to the chronic acidosis, like just feeling generally unwell, maybe lethargic. But critically, you'll see signs of the hyperkalemia. And these can range from muscle weakness and stumbling to much more severe issues like a very slow heart rate, bradycardia, and potentially life-threatening cardiac arrhythmias.
Yikes.
Yeah, high potassium is dangerous for the heart, and you'll also often see signs related to whatever the underlying cause is.
And speaking of causes, what's the most common one for type IV RTA mentioned in the sources?
Feels like there's a big one here.
Hands down, hyperdrenocorticism or Addison's disease, especially in dogs. That's a classic example of not making enough aldosterone. So if you see hyperkalemia and acidosis, Addison's has to be top of your list.
Makes sense. Are there other causes? Yes. Other causes can include primary kidney disease itself, particularly severe tubulointerstitial disease that damages those distal areas. And interestingly, certain medications.
Which ones?
The sources list drugs like ACE inhibitors, ARBs, common heart, and blood pressure meds. Also potassium-sparing diuretics, NSAIDs, and the antibiotic trimethoprim. All of these can interfere with the hormone pathways or the tubule function needed for proper potassium and acid excretion.
Good to know.
Also, severe or prolonged urinary tract obstruction can cause it, and apparently, rarely, certain forms of diabetes mellitus.
That's a really clear breakdown of the types and their potential causes.
Yeah.
So let's say a vet sees a pet with some of these vague signs, weakness, PUPD, maybe a slow heart rate pops up on exam. How do they figure out if it's RTA and which type it might be? How does the source material describe the diagnostic process?
It's definitely a detective process, combining that clinical suspicion with very specific laboratory tests. You can't diagnose it just on signs alone.
What are the absolute key tests they need to run?
Okay, you must get a blood gas analysis. Arterial or venous is fine, but you need it. This confirms the metabolic acidosis, seeing the low pH, low bicarbonate, and most importantly, whether it's that normal anion gap type.
Right.
The sources give us those normal anion gap ranges again, roughly 12-24 MEQL in dogs, 12-25 in cats. Seeing that number fall in the normal range really helps narrow down the possibilities and points away from other major causes of acidosis, like severe kidney failure or certain toxin ingestions where the gap would be high.
And the sources make a really critical point about something else that causes normal anion gap acidosis, don't they? Something common.
Yes, absolutely essential point. Diarrhea. Severe diarrhea is the most important differential diagnosis for normal anion gap metabolic acidosis in pets. Because with severe diarrhea, you lose large amounts of bicarbonate directly from the gut, leading to exactly the same blood chemistry pattern acidosis with a normal anion gap. So that's always something vets need to consider and rule out, usually based on history and exam.
Good reminder.
Okay.
Okay, blood gas first. What other blood tests are important?
A full serum biochemistry panel is vital. You need to pay close attention to the electrolytes, especially potassium. Is it low, pointing towards type I or 2, or high, screaming type 4?
Potassium is key.
Absolutely key. Chloride is often high in these normal anion gap acidosis cases, too, to maintain electrical neutrality as bicarbonate drops. Also, look at the standard kidney values like BUN, creatinine, and SDMA. In RTA, they are often normal or maybe just mildly elevated, which again helps distinguish it from severe generalized kidney failure where they'd be much higher. And importantly, check glucose levels in the blood, remembering that Fanconi connection.
And that leads perfectly to the urinalysis, which seems absolutely critical for RTA diagnosis based on what you've said.
It truly is the tiebreaker in many cases.
Yeah.
The urine pH measured while the animal is systemically acidotic, that's important, is perhaps the most crucial piece of the puzzle highlighted in the sources.
So what are we looking for in urine pH?
In type I RTA, it's inappropriately alkaline, remember, above 5.5, 6.0 dogs, 6.0, 6.5 cats, despite the body being acidic.
Yes.
Of course, you have to make sure a urinary tract infection isn't causing that alkaline urine, so a culture might be needed.
Yeah.
In type 2, as we discussed, it can be acidic, 5.5 in the steady state, because the distal tubule works. And in type 4, it's also typically appropriately acidic, 5.5.
Okay, so acidic body but alkaline urine strongly suggests type 1. Acidic body and acidic urine. Well, that could be type 2 or type 4. How do you tell those apart then?
That's where the potassium comes back in and other urinalysis clues. Look at the urine's specific gravity. It can often be dilute because of the tubular issues messing with water balance, leading to that increased thirst in urination.
All right.
And look closely for things that shouldn't be there. Protein, glucose, amino acids, or phosphate in the urine, especially if the blood levels of those things are normal. Finding those in the urine is like a blaring siren for Fanconi syndrome and points strongly towards type 2 RTA.
Gotcha. Glucose in the urine, normal blood glucose, Fanconi likely type 2.
Exactly. And the urine sediment might also show crystals, particularly those calcium phosphate ones you might expect in type I cases.
It sounds like a very logical step-by-step process based on putting all those results together.
It is. The sources basically suggest this kind of logic tree. First, confirm you actually have a normal anion gap metabolic acidosis with a blood gas.
Step 1.
Step 2, look at the serum potassium. Is it low or high? That's a major branch point.
Okay.
Step 3, check the urine pH while the animal is acidotic. Is it inappropriately alkaline or appropriately acidic? So if you have low potassium, hypokalemia, and acidic urine, you then need to look really hard for those Fanconi signs, glucosuria with normal blood glucose, amino acids, phosphate loss that would point you to type 2.
Right.
If you have high potassium, hyperkalemia, and acidic urine, your next step is probably investigating adrenal function, like an ACTH stimulation test to check for Addison's disease, type 4.
That's a very clear diagnostic path. Are there specific tests mentioned for finding the underlying cause once you suspect RTA and maybe which type?
Yes, definitely. Depending on which type you suspect and what potential triggers you're considering based on the case. That ACTH stim test is essential for type 4 if Addison's is on the table.
Okay.
Checking calcium and parathyroid hormone PTH levels is key. If you're thinking chronic hypercalcemia might have caused type I, maybe screening for heavy metals if there's a potential exposure history, or testing for infections like leptospirosis depending on signs and location.
What about a kidney biopsy?
Renal biopsy is mentioned, but it sounds like it's typically reserved for very complex or unusual cases where the cause remains elusive after other testing. It's usually not the first step.
Okay, so the diagnosis is made. Let's say it's type I or type 2. What does the source material say about treating and managing RTA? What are the goals?
The core goals are pretty straightforward on paper, but the execution can be complex sometimes.
Yep.
Goal 1, correct the body's acidity. Goal 2, manage those crucial electrolyte imbalances, especially the potassium. And goal 3, always try to identify and address any underlying cause you can find.
And the main way to tackle the acidosis itself?
Alkali therapy. This is really the cornerstone of treatment for type I and type 2 RTA, where the main problem is losing base or not excreting acid properly.
What kind of alkali?
Oral sodium bicarbonate is a common option. The sources give some examples, starting dosages maybe around 1 to 2 milliequivalents per kilogram per day for type 1.
Okay.
But here's a key point they emphasize. For type 2, because of that ongoing bicarbonate leak from the proximal tubule, you often need much higher doses, sometimes 5 to 10 times that amount or even more, just to keep the blood bicarbonate level somewhere near the normal range. It can be a real challenge.
Wow, that's a huge difference in dosage and must take careful monitoring. What about potassium citrate? That was mentioned in the sources too.
Yes, potassium citrate is often a really good choice, particularly if the animal also has low potassium hypokalemia, which is common in both type I and 2.
Why is it good?
Because the citrate part gets converted to bicarbonate in the body, so it provides the alkali you need to fight the acidosis, and it also supplies potassium. So it tackles two problems at once.
Yes, sir.
Yeah. The sources suggest starting doses, maybe 40, 80 milligrams per kilogram, or 0.5, 1.0 mEq/kg for type I. But again, dosage needs careful titration. And you'll likely need additional potassium supplementation on top of the citrate if the hypokalemia is severe to start with.
Does the overall management approach differ significantly between the types, beyond just the alkali dose for type 2?
Yes, it definitely does tailor to the type. For type I, it's primarily about that alkali therapy and potassium supplementation if needed. Plus, you need to actively manage those calcium complications.
Right.
Things like encouraging hydration, maybe feeding a wet food to increase water intake, sometimes cautiously using specific diuretics like thiazides, which can paradoxically help reduce calcium excretion in the urine sometimes, and critically treating any underlying cause like high blood calcium if that's what triggered it.
Okay. And for type 2, you mentioned needing those much higher alkali doses. What are the challenges there?
Right. Those high doses are necessary because the kidney is constantly losing bicarbonate, but they definitely carry risks. You can get sodium overload from all the sodium bicarbonate, which can be tough on the heart, especially in older animals. And giving lots of bicarbonate can sometimes actually worsen the hypokalemia because you're driving more sodium delivery down to the distal tubule, which encourages potassium loss. So aggressive potassium supplementation alongside the alkali is usually essential for type 2.
And what about the Fanconi aspect of type 2?
Yeah, for the other Fanconi signs, the loss of glucose, amino acids, phosphate treatment is mostly supportive care. Making sure they get adequate, highly digestible nutrition, maybe replacing specific lost vitamins and minerals if needed, ensuring they stay well hydrated because they often have significant PUPD, and really focusing on treating any identified acquired underlying cause like stopping an offending drug or treating an infection. That's your best shot at improving the Fanconi.
Okay. Now, type 5, the one linked to Addison's and high potassium, how's that managed?
Here, the absolute #1 priority is treating the underlying cause. That's paramount.
If it's Addison's.
If it's Addison's disease, then definitive treatment with mineralocorticoid replacement drugs like fludrocortisone pills or DOCP injections, plus usually some glucocorticoid replacement, is typically curative for both the hyperkalemia and the acidosis. You fix the hormone deficiency, you fix the RTA.
That's great when it works.
Yeah.
What if the hyperkalemia is severe and dangerous right now?
Right. If it's severe and life-threatening acutely, then emergency treatment is needed immediately while you figure out the cause. This involves things like intravenous fluids to help flush potassium out, sometimes giving insulin along with dextrose or maybe bicarbonate to shift potassium temporarily from the blood into the cells.
Right.
Giving calcium gluconate intravenously doesn't lower potassium, but it helps protect the heart muscle from the dangerous effects of high potassium. And crucially, immediately stopping any medications that could be contributing, like those ACE inhibitors or potassium-sparing diuretics we mentioned.
Do you still give alkali for type 5?
Sometimes alkali therapy might still be needed later if the acidosis persists after the hyperkalemia is controlled and the underlying cause is being treated, but often fixing the primary problem, especially if it's Addison's, corrects the acidosis without needing separate alkali treatment.
It sounds like these cases require pretty intensive, often lifelong monitoring, regardless of the type.
Oh, they absolutely do. Regular checkups are key. You'll need repeat blood work checking electrolytes, particularly that potassium level, running blood gases to make sure the acidosis is staying corrected, and monitoring kidney values over time.
And urine tests.
Yep, urinalysis is needed periodically too. Checking urine pH to see how therapy is working, screening for crystals or signs of infection. Just monitoring body weight and hydration status is important, keeping a close eye on those clinical signs at home, and maybe occasional imaging like x-rays or ultrasound to look for progression of kidney stones or nephrocalcinosis. It's definitely a commitment.
What's the general prognosis for pets with RTA, according to the sources? Is it good, bad, somewhere in between? And what are the potential complications if it's not managed well?
Yeah, the prognosis is really variable. It can actually be quite good if you can find and successfully treat the underlying cause, like Addison's disease, or if it was caused by a drug you can stop or a toxin you can remove, and if the acidosis and electrolyte imbalances are well controlled with ongoing medication and monitoring.
Right.
But it's more guarded, maybe fair to guarded, if the RTA is idiopathic, meaning we can't find a specific cause, or if it's caused by something severe and untreatable, like advanced amyloidosis. Because even with treatment for the RTA itself, complications can still develop over time.
Maybe if it's caught late.
Yeah, the prognosis is unfortunately poor if the condition is diagnosed very late, and severe irreversible complications like significant chronic kidney damage or debilitating bone issues have already occurred. Early diagnosis really matters.
And those complications, if it's left untreated or just poorly managed, sound pretty serious. Can we just quickly recap the big ones?
They really are serious. So the big ones to remember are severe potentially life-threatening metabolic acidosis itself, which can impair heart function and muscle function. Critically dangerous potassium imbalances, either way too low, hypokalemia, or way too high, hyperkalemia,
Yeah.
both of which can cause fatal heart arrhythmias.
Okay.
Then there's the nephrocalcinosis, those calcium deposits actually forming in the kidney tissue, especially seen with type I, which can progressively damage kidney tissue and lead straight to chronic kidney disease.
Right. The stones and deposits.
Exactly. And relatedly, urinary stones, urolithiasis, primarily calcium phosphate or maybe calcium oxalate, again, especially with type I. Then you have the potential for bone disease, renal osteodystrophy, and poor growth, particularly in young animals, from the chronic acidosis interfering with calcium and phosphorus balance. And really, just the overall progression to more severe, irreversible chronic kidney disease is major risk down the line. Plus things like malnutrition if they feel unwell and aren't eating, and maybe recurrent urinary tract infections. It's a whole cascade of potential problems.
That really drives home the importance of getting that diagnosis and
Yeah.
starting appropriate management.
Exactly. It makes a huge difference.
So to kind of bring this deep dive to a close, renal tubular acidosis in dogs and cats is, well, it's a pretty nuanced set of disorders, isn't it?
Definitely complex.
It's characterized by that very specific finding a normal anion gap metabolic acidosis that stems from these distinct defects in the kidney tubule's ability to handle acid or bicarbonate. It's really different from just general kidney failure.
And pinpointing it requires, a high degree of suspicion from the vet, plus a really careful look at those specific lab results. The blood gases to confirm the normal anion gap acidosis, the electrolytes to check potassium status, and crucially, the urine pH measured when the body is acidic to help differentiate the types.
And here's that nugget of hope again that the source has emphasized. While it often requires lifelong care and monitoring, aggressively treating the acidosis, carefully balancing those electrolytes, and importantly, finding and addressing the underlying cause whenever possible, can significantly improve the pet's quality of life and potentially prevent many of those severe long-term complications we just discussed.
It's really a powerful illustration of just how specialized the kidney's various roles are. I mean, a problem in this tiny, complex acid-base handling machinery within the tubules can have these massive ripple effects throughout the entire body.
What's truly fascinating to me, thinking about this, is how a seemingly localized problem in those kidney tubules, just their ability to handle acid and potassium properly, can cascade into issues that affect things as seemingly unrelated as bone strength, muscle power, or even potentially life-threatening heart rhythms.
Yeah.
It really underscores the incredible interconnectedness of all our body systems.
Absolutely. And it absolutely highlights why you can't just stop at treating the acidosis symptomatically, just giving bicarbonate. Finding the cause behind the RTA is so critical because, as we said, you might uncover a completely treatable primary disease like Addison's that, once you fix that, the RTA just resolves entirely. Digging deeper is key.
A lot to think about there. Well, thanks for joining us for this deep dive into canine and feline renal tubular acidosis.